projecting the demand over the next 5 and 10 years for these services, and looking at it on a geographic basis, and then where are the current services today and where are some of the gaps in capacity. So that's some information that we can also bring forward and share with you, both in terms of developmental disability, but also long-term care services for the elderly.
And Senator Valentino wants to fire one act.
I missed this.
On my message, I want to not necessarily fire one, but something that's near and dear to me. And I know you remember my father, because when he used to, whenever he was patient all the time, he passed away of Alzheimer's. And so I have a question, where does that relate to in here? When you talk about intellectual disabilities, we have a growing demand for people with Alzheimer's, home care situations, and as close a family as we had, it was extremely difficult. It almost killed my mother because, you know, people don't have those services and stuff. Where does that fit into here, knowing that there is going to be this curve that is going up right now for that? And intellectual disabilities, I guess I'm not sure what that means, and where does that Alzheimer's go into? Because it seems like we all know somebody with Alzheimer's.
Right, so it's not reflected in these services for intellectual and developmental disabilities. It is part of our larger system challenges, both in terms of support and services for nursing facility services, home-based care within the Medicaid program, assisted living are private non-medical institutions, the vast majority of which are for elderly. One of the areas that we have been discussing, Maine has the most rigorous eligibility levels for nursing facilities dating back to 1994 when significant changes were made to increase the eligibility levels related to the acuity level to get into a nursing facility. One of the areas that we have been looking at and evaluating is whether Alzheimer's dementia alone should be part of the consideration for admission into a nursing facility. So it is certainly an area, as we look at it, as I mentioned, as we look at the demand for long-term care services and looking at the projections, trying to assess the system and its capacity. It is an area also that we tend to be in denial about, and as families begin to navigate the system, it's incredibly complex and complicated. So we've been looking at ways to both improve that for families so that they are able to find services that support their needs, but also understanding how do we ensure that we have the right array of services to support, especially as we look at the increasing percentage of individuals with dementia, with Alzheimer's in these facilities.
And Senator Cates.
Thank you, Mr. Chairman. Thanks, Commissioner. First of all, I just want to say that this PowerPoint presentation is about as good as any I've ever seen. It's in English, I can understand it. It presents a lot of complicated information in a very clear way that I'm going to be able to go back to in a couple of weeks and actually understand. So thank you for that, for staff. I did have a question on page 24 talking about the wait list. And I understand the numbers on the wait list. I understand the average per person and the cost. The third category, the annual state cost of fund, what is that? Is that what we're spending now? Is that what it would cost to pay down those wait lists?
Right.
It wasn't clear.
So yes, so those are the state dollars that would be needed, and of course for those programs that are at the top part of the page, those are 100% state funded. The section at the bottom of the page are Medicaid programs, so the state dollars are what are needed to address the numbers on the wait list, and then that would obviously be matched with federal dollars. So the total cost to fund the wait list is the final.
Thank you.
Well, the 54 million is the total state funding. 119 million would be the state and federal.
Continue on.
So I want to transition, as I mentioned, into where we are within the department and within the Office of Maine Care Services in the overall management of healthcare. And I'll pause a little just to talk about where this administration has been related to Medicaid managed care and our focus instead on what we refer to as our value-based purchasing strategy. So we consciously chose to move away from the Medicaid managed care, the traditional Medicaid managed care model. There are many states throughout the country that have Medicaid managed care with a traditional managed care organizations or several managed care organizations that are overseeing the state's Medicaid program. We had serious concerns about whether or not that would support our goals for improved utilization management, that we wanted to be able to partner with local providers in support of the infrastructure that they were investing in, designed to improve care delivery and management of care, specifically in the primary care setting, as physician practices and other providers were investing in and supporting care managers, case managers, social workers within the practice setting. We wanted to be able to partner effectively and look at ways in which to support that without creating and adding additional administrative costs that may not necessarily be a value add. There are studies around managed care companies in terms of their approach, and we simply had not seen the kind of focused effort around healthcare management, utilization management that we believe was so critically important within the Medicaid program. So I'm going to ask Stephanie maybe to just intro some of these slides, and then I want to talk a little bit more about our some of our key initiatives, our emergency department collaborative, our health homes, and our accountable communities. But if you could just maybe set that up, that would be great.
Thank you, Commissioner. And we are starting on page 25, and really at the top you'll notice why the change. And as the Commissioner mentioned, we're really trying to break down silos, and we're also looking internally and focusing on moving away from the volume-based. I continue to use the widget maker, being a transactional payer, to a payer that is invested in and investing in health outcomes for members, and not just paying for how many 15-minute office visits can we pay for in a year, but really focusing on health outcomes and quality measures for our members to lead the most successful lives that they can. And so why the change? Our system historically within Medicaid has been designed to reward the volume-based perspective. We want to change the tide, and we want people to be focused on patient experience. We want there to be greater collaboration between patients and their providers. Patient engagement in decision-making, shared decision-making between a provider and a patient is critical as we look towards focusing on outcomes and changing our reimbursement structures to focus on more than just a 15-minute office visit, but something that is based in quality and outcome. So as the Commissioner did mention, 20% of our Maine Care members incur 87% of the cost, and 5% equate to 50% of our total expenditures, and that is a key statistic that we will continue to focus on because it is critical. And within that 5%, or even within that 20%, we're always looking at where are there inappropriate utilizations or over-utilizations of services that we can target, and we can, within our own resources within the Office of Maine Care Services or the Department of Health and Human Services, or community resources, as the Commissioner mentioned, where we can engage and come to the table with the patients, with the members that we're serving, to have greater outcome and greater engagement in care. Another statistic that we talk about a lot is the fact that 20% of the individuals on Medicaid have at least one long-term or chronic condition. it is critical that we make sure that we get early entry into primary care for prevention, education, and treatment. What we want to try to avoid is that 20% of the individuals becoming our top 5%. And we really have some key initiatives that are focused on making sure that we're identifying those prevention, education, and treatment services so that we can prevent more individuals coming into that top 5%.
I'm going to jump in on the Emergency Department Collaborative. This is an initiative that started with a pilot, expanded in 2011 to all of the hospitals with emergency departments to evaluate and support in a more effective way super utilizers of healthcare services, in particular here in emergency department services. And we're talking about individuals who are in the emergency department 40, 50, some upwards of 100 times a year. And these are individuals with complex needs, substance abuse, mental health, medical, complicated chronic disease, who have had challenges appropriately accessing services in the community at the primary care level. I am so proud of the work that has occurred within the Office of Maine Care Services around this emergency department collaborative, because fundamentally it is about how to advance a patient-centered, person-centered approach to care delivery, to truly convening community teams around these individuals to better support their access to primary care. It's clear that for some of these individuals, they have burned bridges with primary care providers. They've been fired from their practices or from community mental health agencies. And our job has been to reconvene people around the table to look at what is the care that is needed and how best to support the individual. And we've seen incredible success in reducing their emergency department use. This is an effort that is truly foundational to the additional initiatives that we have launched. I shared yesterday with the Health and Human Services Committee, one of our great inspirations for this work is a physician out of Camden, New Jersey, Dr. Jeffrey Brenner. He was the focus of an article in the New Yorker magazine back in January of 2011 about his work, certainly in a impoverished area, certainly an urban area in New Jersey, and he was evaluating what he was seeing as a true challenge within their healthcare system with the super utilizers there. And we have worked very closely with Dr. Brenner in his work looking at effective care management, care coordination that truly can make a difference. One of the examples that he used that I shared yesterday was a diabetic gentleman who was just repeatedly in the emergency department, and they could not figure out why he wasn't able to better manage his diabetes, and decided to do a home visit and observe his administration of the insulin. And when they saw him draw the insulin, they realized that he was legally blind and was not able to determine whether or not he was getting the insulin. But just that as an example of just the person-centered approach that we have taken on in the Emergency Department Collaborative, and the intent is to complement care managers within the hospitals and within the community providers, and to fill the gaps in areas of the state where there may not be a robust array of care managers and case management services. You'll see on page, I'll just move to page 28, that the average number of emergency department visits pre-intervention was 13 and 11 months, and again, many more for some individuals. And the average number of ED visits post-intervention was 6 and 12 months. We have managed over 2,000 individuals in this program and are currently managing a little more than 1,000 individuals. And this is with a relatively small staff in the Office of Maine Care Services. We've saved over $9.9 million, state and federal, since this program began. And you can see on page 29 just a graph that relates to the reduction in the use and the cost as it relates to the frequency of emergency department visits, but certainly The larger goal here is helping to stabilize and improve their health. The other value here of the engagement with these individuals is we certainly don't expect that we're going to reduce their emergency department use to zero, but as they begin to escalate with increased use of the emergency department, we now have a team that can immediately take action and come together to help address that escalation and reduce their ultimate need for the emergency department services. So this work has really been foundational, as I've said, to where we want to continue to expand the role of the Office of Maine Care Services and our care management team. I'm going to have Stephanie just walk through, as part of the Affordable Care Act, states were afforded the opportunity to provide enhanced funding for primary care practices that embraced this health home model, which is building on the patient-centered medical home. And Maine, having been very active in the development of patient-centered medical homes, we were very excited about the opportunity to expand that to create the health home model. Do you want to describe that, Stephanie?
Sure, and on slide 30, we go into the health homes initiatives, and as I mentioned yesterday to the Health and Human Services Committee, we weren't very creative with our naming, stage A and stage B, but that's what they've come to be known as. And really, stage A, and as the Commissioner mentioned, this was temporary enhanced federal funding. We did implement in 2 separate phases. And stage A was focused, and it was implemented in January of 2013, and it really focused on individuals with 2 or more chronic conditions, or 1 chronic condition and at risk of another. And what I will focus on is the fact that there are currently roughly 50,000 individuals who are enrolled in our Health Homes Initiative, and what that really focuses on is really geared towards is making sure these individuals are in and accessing their primary care providers. So of the 170 primary care practices around the state, it is making sure that individuals are getting their hemoglobin A1C if they're diagnosed with diabetes, and they're having those regular checks. And it's really focusing on making sure that individuals are accessing their primary care, that there are nurse care managers that are reaching out to individuals to make sure that they're going to come in and get in for their appointments, making the phone calls to make sure that they're taking their medications appropriately, that they're following up on discharge planning when they are released from hospital inpatient. And the goal here with stage A, as the theme is across a large number of our initiatives, is we are trying to keep people out of the emergency department. We want their primary access to care to be their primary care provider's office. So it's establishing a relationship with individuals, and specifically targeting those with multiple chronic conditions. And again, education, prevention, and treatment. For our stage B health
Stephanie, if
homes.
you don't mind, question from Representative Gattini.
Thank you, Stephanie. So, for many years, the borough run the PCCM program, the Primary Care Case Management Program. And where members are aligned up with a primary care provider. How does this program interact with that, impact? I mean, ultimately, is this going to be like a replacement for that, or I'm just understand around that.
That's a great question, Representative. And the program that Representative Gattini was talking about probably was implemented over 10 years ago. And it was a small enhanced fee per member per month, and I think it was an additional $2.50 per member per month on your patient panel.
It was originally supposed to be an alternative to going to a managed care program back in the late 90s.
That's true. And a large portion of our population was linked in with a primary care provider. And Health Homes has built upon the PCCM program, and we're actually in the process of looking at our PCCM program, trying to understand where's their alignment, where are we talking about the same individuals, and if there are individuals that aren't in a health home that could benefit from being in the PCCM program, finding those individuals, linking them up, but also looking at from a policy and a regulatory perspective, do we have the right incentives? So 10 plus years ago when we implemented PCCM, it was really focused on greater access, so night and weekend hours and on-call perspective. And I would frankly say the PCCM program probably hasn't kept pace with where the healthcare industry has gone. So we're really looking at right now from a value-based purchasing perspective, how do we make better alignment of that program to serve a greater number of members that may not fit in our health homes, but that they're receiving the same care and we're all focused towards the same outcomes.
Thank you.
And Representative Hymanson, right?
Thank you.
Yes.
Yeah, that's right. So just a perspective, I've been in a position for 30 years in private practice that just ended 6 months ago. And during most of my practice, it was the more things changed, the more they stayed the same. So the system really did not change very much, even though it looked like it was. The last 7 or 8 years have been transformative in healthcare management and the way that systems are being formed. And what this rollout that you just heard really is emblematic of that, what I would say is a mega change in healthcare alignments. As I said in Health and Human Services, I congratulate you on moving with this trend. It's very complicated. There are so many moving parts. In Franklin County at the hospital when we were there, the CEO told us about how they saved. They reduced the number of people coming into the emergency department. Great, they worked really hard on it, but what did that do? Because they're still fee-for-service, the hospital lost money. And so they're having trouble with their operating expenses. So the systems just haven't dovetailed in the way that they will in 5 years, 10 years. It's a real struggle.
I think that's a very good point. I had the chance to hear a similar discussion with that CEO, and it was we're doing everything right and losing money because the payment reform has not, as you said, has not effectively kept pace. Now these initiatives that we've launched are an effort to try and reward for performance and quality and help to support that business transformation. The challenge, of course, with anything, as you said, it's huge change. And it's change in the business model, and so for Medicaid to both support that change, but also work with providers to transition their business models so that we're all working for those same shared goals of improving health outcomes and having the payments support the right alignment with the resource intensity for the individuals. And that is certainly true as we begin to talk about the behavioral health homes, because that is a very different model with a global payment. It is, again, trying to support the integration of behavioral and physical health, but it is transformative. And we have been working closely with providers because we want this to be successful, but we understand the challenge of change and the risks associated with it when you're trying to transition from how your business has been structured around current payments to what this new payment opportunity holds for promise. So that, I think, is a great example. We know where we want to be on the integration of physical and behavioral health, but we may see some challenges along the way as we try to embrace this and hopefully to support as many providers as possible that are participating in this model. Would you just describe a little bit more?
Sure, and I do appreciate those comments as well. And before I jump into CHB health goals, I will, and we'll talk about this a little further on in the presentation, but the State Innovation Model Grant, or the SIM grant that the state of Maine was awarded, I think really emphasizes the innovative nature of the work that Medicaid is doing, as well as the innovative work across all payers from the state of Maine's perspective. And we can talk a little bit about that, but one of the things that I think is very important is as we try to turn the tide on the healthcare delivery system, it's that we are all talking, we're all at the table and we're talking, and that we're aligning where it's appropriate to align. And we talked about this a little bit yesterday in the Health and Human Services Committee, but it's looking at quality measures and making sure that we're not asking as a payer community for 15 distinct measures for each payer submitted in a vastly different way. If we're all trying to focus on really, did a diabetic get his or her hemoglobin A1C tested on a regular basis? And there's got to be standardization, there's got to be alignment, and so there's a lot of work collectively across the state of Maine going on. One of the reasons why the state of Maine was awarded the SIM grant was the innovative nature of the work that we're doing. through health homes, through the patient-centered medical home pilot, and a lot of foundational, the emergency department collaborative, a lot of foundational components. And I think it works into how do we then move that forward with integration of behavioral health? And our stage B health homes is really designed to do that. Those were implemented in April of this year. Very new when we start talking about transformation and innovation within the healthcare delivery system. The reason why we're focused on this is individuals with serious and persistent mental illness, adults, and children with serious and emotional disturbance have a very fractured and siloed healthcare delivery system. They are seeing their behavioral health provider for their mental health or behavioral health diagnosis, and often not seeing a primary care provider for their chronic conditions, in which most of them have some. A statistic I mentioned yesterday at the Health and Human Services Committee is individuals with serious and persistent mental illness die 25 years younger than their counterparts. And a staggering statistic on its own, but when you couple that with the rest of the statement, which is, and they are not dying because of their behavioral health diagnoses, they're dying because their chronic conditions are not being managed. And really, the Stage B health homes is focused on trying to get in and have better integration, alignment between behavioral health providers, establish relationships with primary care providers, so when they have an individual who is accessing the healthcare delivery system through a behavioral health agency or a clinic, there is a primary care provider that they can link them up with so that they can also have their chronic conditions managed, treated, and evaluated at a minimum. As the Commissioner did mention, this is a significant deviation from the general fee for service. Again, the 15-minute office visit, it is a capitated payment in which we are expecting there to be care coordinators that are engaged in these relationships and established relationships with primary care providers. So there is that warm handoff for individuals who are accessing care through their behavioral health providers, but also need that link to primary care as well.
You know, I want to say with regard to the behavioral health homes, as you hear from providers that may be expressing concerns or frustrations, we need to hear, we need to be open to understanding whether the model is functioning as we intended, whether the costs that have been taken into consideration in developing the rates have been accurately reflected. We certainly are meeting with providers, but I just want to encourage you all, as you hear any of those concerns, to certainly share those with us and encourage your providers to be in touch with us, because we need to achieve success here, but we've got to be open to making potential mid-course corrections, if you will, to the model. Accountable communities. I'll intro it and then have you. So Medicare launched pilot accountable care organizations, and Maine has a number of pilots underway with the large health systems. Medicaid has also been encouraged nationally to pursue similar models. We began work several years ago on designing this model. It's incredibly complex, but is really embracing this movement away from the volume-based payment structure to that which is rewarding quality and improved population health outcomes. We wanted to certainly model it to the extent possible on Medicare, so that as providers in Maine have already become accustomed to that and participating in that, that this would not be a huge departure to the Medicaid program. This is in its infancy. We just implemented the accountable communities in Medicaid this past August. So still in the throes of the early implementation phase, but if you want to just outline, and there's a slide that I slipped in here that you may not be aware of to show us.
Yeah, I saw that.
Okay,
Thank
awesome.
you. Appreciate that. So on slide 34 and 35, the Commissioner did a great job of overviewing the Accountable Communities Initiative. And again, we can focus on the bullet points. Why accountable communities? Why are we moving in this direction? Again, the theme is the reduction in inpatient readmissions, the reduction in non-emergent use of the emergency department. And we continue to focus on appropriate utilization and the triple aim of the right service in the right place at the right cost. And when we focused on and when we looked at what was going on nationally, specifically in the Medicare population, as well as in the state of Maine with the State Employee Health Commission, as well as some commercial plans who were engaged in the accountable communities perspective, accountable care organizations, perspective, we really thought, I think this is a great place for the Medicaid program to be. And on slide 36, I'll get into a little bit of the technical details because the Commissioner did a fantastic job of why accountable communities. So I'm going to throw terms around about membership attribution, savings models, and really we went out and we asked for people to apply to become lead entities within our accountable communities. And again, these were entities who were willing to take on responsibility of management of a group of individuals that would be attributed to them. And on slide 36, there's a heading here that talks about a shared savings model. So when we went forward, there were two models in which an accountable community lead entity could engage in. One model is a shared savings model where there is no risk to the entity. That means that if they are able to better manage the care of their attributed membership, if they're able to reduce the total cost of care of that membership, as well as score highly in quality measures, as well as a variety of patient experience measures, then they are able to share in up to 50% of the savings that they achieve. Model 2 is a model in which they could share up to 60%, but there is downside risk, meaning that if lead entities don't achieve certain savings or they don't achieve certain quality benchmarks, that they would be responsible for reimbursing the department. As you can imagine, all 4 lead entities chose Model 1, a shared savings methodology. However, we have had a couple of lead entities say that they would be willing to look down the road with experience at the Model 2, which is a downside risk model. And really, again, that is focused on identifying a total cost of care for their membership, appropriate reduction in that cost of care, as well as being able to share a percent of that savings. And that percent of the savings up to the 50% is really driven by quality measures. And so we're going to focus on the savings, but really how did you get there? And that's really important to us to focus on.
And I just want to commend the primary care practices, the community mental health agencies, the hospitals and health systems that have stepped up to participate in these innovative models. We certainly appreciate the level of change it involves, and we are appreciative of their partnership as we seek to improve health outcomes for Maine care and reduce the rate of increase in our overall medical spend. We've got just a handful of other initiatives. I think, again, the intent here was to try and provide this high overview of the number of different initiatives that we've been implementing to more effectively manage, as I've said, how care is accessed and how services are effectively utilized. We have a number that we've been focused on in pharmacy and pharmacy management. And I thought, Stephanie, if you want to go through the pharmacy management and certainly maybe just do those as quickly as possible, and then into radiology and pain management.
Sure, and I'm always willing to either bring back more information or we can have further details. I know we did talk about this yesterday in the Health and Human Services Committee. In 2014, we, with our contractor, World Health Systems, who is our pharmacy benefit manager, engaged in a comprehensive pharmacy management program. Mainly that was driven by the fact that there are multiple, and I will use the term that's on the industry, miracle drugs that are being introduced to the marketplace. And these are extremely high cost drugs. So there is one drug known as Sovaldi, and you've probably heard about it on the news, but for a 90-day supply, it is upwards of $85,000. Now, this is supposed to cure individuals who have hepatitis C, but as you can imagine, with something with that price tag, we want to make sure that there are a lot of things that have happened before that individual starts taking that drug regimen, while they are taking it, and making sure that we are monitoring their adherence and as well to that drug regimen. So in collaboration with rural health systems, we have been actively working with 700 plus members, and really that is from the time that they are identified and the request for the prescription is identified from a group perspective. It's calling the provider, making sure that they understand, the provider themselves understand the other medications that this individual may be on, understand that this person really meet the clinical criteria for this drug and this medication. And once that has been decided, it's follow up with the member, making sure that either having any side effects or there are any drug interactions, that we need to be focused on, because what we want to make sure is that individuals who can tolerate can finish this treatment. Because first of all, it is pegged as a cure for hepatitis C. In 5 of the individuals that we've been tracking, we have seen that success. So very good success, but at a rate of $85,000 per 90-day supply. We want to be focused on making sure that the right individuals are receiving the medication and that they're following through with the prescription orders, the physician orders, and that they're making, and again, less fraud, waste, and abuse from that perspective as well, if there's constant monitoring and going on. And as slide 37 talks about, it's not only Sovaldi, it's not only hepatitis C that we're focused on with this intensive care management. It's HIV, it's high-cost cancer drugs, cystic fibrosis, rheumatoid arthritis, a lot of those high-cost drivers, which there are a lot of these drugs coming onto the market, and just making sure that we're ahead of that and making sure that we're aggressively managing that as well. On slide 38 and 39, the Office of Maine Care Services implemented a new pain management policy. It was out of legislation from the Appropriations and Financial Affairs Committee, I would say probably 2 years ago now. And again, what this focused on was looking at the difference between acute pain and chronic pain, and establishing criteria in which we could have prior authorizations that were put in place, appropriate clinical use of opioids for pain management. We have been able to, on slide